Hello people, how are you? In this video we want to look at this topic HypoNatremia. Hypo is less, right? So it is less. What is less? Sodium. So sodium is actually called as sodium is represented by Na, but what exactly is natrium, right? So there is low sodium. So why is this a medical topic? Have you heard of saline? So normally when a patient gets admitted, they give IV fluids like saline, right? So it will prevent water loss. So if the person has hypotension, you should always check the blood pressure before giving IV fluids, right? So if the blood pressure is low, they can give this saline drip, right? So it will help in the retention of water in the body tissues. Okay, so if there's dehydration, so they will give saline. And you have heard of this oral rehydration salts, right? That is ORS. What will be there in that? Sodium. Where is sodium here? So sodium, they have shown here sodium 90, 45, 75. So normally what ORS you give people is this, right? Reduced osmolarity. This one we give people, right? We give this one to people and with 75 millimole per liter, is it? Sodium is there, 75, okay? So this is the normal ORS that you give people, okay? Then there is one reduced sodium also in case they are having edema, they have a lot of fluid retention, then they'll give a reduced sodium one. But normally you will give this ORS which has 75 milliosmol per liter sodium, okay. So now in the exam they are asking you HypoNatremia, topic they are giving you. So what is this? So you have to explain step by step, right? So normal sodium levels are 136 to 145 millimoles per liter. But where? Where is it? It's in the blood or it's the extracellular plasma? What is this? Normal sodium levels. Serum electrolyte. So it is in serum, correct. So it is in the serum. Serum electrolyte. So that is in the serum. That is the blood. It's a part of the blood, not the cells exactly, right? So serum electrolytes, when you check, you'll check the normal sodium levels. That will be between 136 and 145 millimoles per liter. What are we looking at, people? Very good. We are looking at HypoNatremia, hypo. So we want to look at what will happen if it goes below 136, correct? And why will it go? All that we want to look at in this video. So HypoNatremia, understand people, how do you define it? It is defined as the serum sodium, remember, serum sodium levels being less than 135 millimoles per liter. Okay, so it is a common electrolyte. The sodium is a very common electrolyte, and why do you think this level will go down? What happens if it goes low? All that we will look at now. So let's make a new thing here for HypoNatremia. Definition you got: serum sodium less than 135 millimole per liter. Very good. Next, what are the causes of HypoNatremia? Okay, so basically what are the ways you lose stuff from your body? All that will lose sodium. Like you're vomiting, sodium gone. You're passing too much of stools, that is diarrhea, sodium gone. Urine, you're urinating so much, sodium gone. Okay, so vomiting, diarrhea and excessive urination, that means some renal cause. Okay, it could be some diuretic therapy, you're taking some drugs which will increase the urine output like thiazides, etc. Right, then you have this adrenocortical failure they are saying. So you're making a lot of urine, you're not able to retain water, kind of a thing. So all these conditions, okay, so vomiting, diarrhea, excessive urine because of renal loss, okay. And then if there are burns, okay, that they have mentioned here, can you see burns? So if there are burns also, you are losing a lot of sodium. So this will all lead to hypovolemia. So there will be less water. Okay, hypovolemia. So what will happen? Then how this will lead to a condition, because you are losing sodium and that will take away water also, right? Your vomiting means you're losing sodium and water. So hypovolemia. Okay. So one part you understood, right? People, you understood the main part. Vomiting, diarrhea, renal loss, burns. Okay. Now let us go to the next part here. Polydipsia. You're drinking so much water. Water infusion. Why will you infuse water into somebody? That's really strange. Electrolyte free water infusion. You're just directly infusing water into that person. So there's no sodium, right? Or relatively less sodium will be there. Then SiADH, that is this is that condition where you have that ADH will be more. So what will happen if ADH is more? It's antidiuretic. It will try to keep water in the body. So there is water intoxication. Okay, that's what they're saying. Syndrome of inappropriate hypersecretion of antidiuretic hormone. SIADH, right? SIADH. That is only this condition that they are telling. So what will happen? Water intoxication. Okay, so it feels like sodium is less. Then hypothyroidism. What happens in hypothyroidism? Edema will be there, right? Why? Why those people will be having metabolism will be so less. So they will be having like edema, right? So that in that sense the sodium will be less. Okay, because the water seems a little more. Then coming to, actually they are saying this is a euvolemic condition where the volume of the water is correct only. It's perfectly right. Though you are drinking so much water, though you are giving water infusion, though you are having edema in hypothyroidism kind of a thing, it's still they are calling it as euvolemic. I think the body is trying to maintain it. Okay, don't bother much about this. Now let's move on to the last one here, hypovolemic. Hypovolemic means, sorry, hypervolemic. Hypervolemic means there's so much water. Don't zoom. So much water. Okay, we'll draw a big bucket here. Wait. So basically, there's so much water, so it's more like a dilutional hyponatremia, I'm thinking. So what will happen here, like in congestive cardiac failure, nephrotic syndrome, chronic kidney disease, it's not able to excrete the water, it's retaining water, is it? So much of water, so it will give more like a dilutional hyponatremia, I'm thinking. Okay. So what is the cirrhosis? Cirrhosis of what? Are they referring to the liver here? So basically these are the conditions. So mainly you remember, what and all will you remember? Losses are more. Okay. So vomiting and diarrhea and burns and what else we saw? Renal losses. Okay. All this we remembered. Okay. These are the losses are more. Intake of water is more. Okay. That you put as another condition. Intake of water is more. Okay. Intake of water is more. Okay. So you're not taking enough sodium, you're taking more of water. That's what it looks like. So that's why hyponatremia, right? Then what else? So other things they're telling is congestive cardiac failure and other cirrhosis of liver, etc. Basically where you have again water being more than the sodium, what it should be. Okay. Because you can see guys, sodium, what they're saying, it is millimoles per liter. So if this liter increases also, the sodium level will appear less. Okay. So that is why they are trying to combine both this volume thing in this. You got it right? For this condition, no, why are they putting in that person electrolyte free water infusion? Why are they giving water infusion? Like you have heard of this prostate surgery, right? Prostatectomy, where they are giving irrigation fluid for the bladder. Okay. Sodium free bladder irrigation fluid after prostatectomy. So that can lead to absorption of this water and can lead to this slightly excess water. That's why, okay, they are saying. Or you're giving intravenous dextrose solution. Are you focusing people? So in prostatectomy, or if you're giving dextrose to people, dextrose is what? Glucose, right? So you're not giving sodium, you're not giving electrolytes. Okay. So that is why they're saying that could be a volume, could become little more. But still clinically the patient is euvolemic. That's why they have put it in euvolemic. Okay. Euvolemic. So what is the feature of this hyponatremic guy? See, you know the features, causes already. If he's vomiting, if he's having diarrhea, if he has burns, or if he's having too much of urine loss. Urine loss actually you cannot see as a symptom. He'll not come complaining that much mostly. But yeah, so if there is hyponatremia, what will happen? If sodium is less, there can be a disturbance of cerebral function, okay? So there can be anorexia. Again, that itself leading to all this lethargy, seizures, coma. So let's take the seizures. Seizures can be if there is excess sodium also, right? Anorexia, vomiting, delirium, lethargy, seizures, okay, coma. Seizures is if there is hyper also, right? Hypernatremia. So basically you have to be aware of all this, okay? Usually We always do a serum electrolytes test for the patient, right? So what will we check? We'll check sodium, potassium and chloride. Okay. So very important to know. The thing about sodium is they did not talk about any ECG and all that, but in potassium ECG changes etc. they will tell, right? So how will you investigate hyponatremia? You will just do a serum electrolyte test. Okay. Look at this. They are trying to explain what exactly is happening to the brain here. Yeah. If there is slowly developing hyponatremia, then there's no problem. But if there is a sharp fall, if suddenly there is a fall in the sodium levels, acute hyponatremia, that will lead to swelling of your cerebral cells, cerebral swelling, cerebral edema. Okay, so that is where this thing is important. Acute hyponatremia is going to be dangerous. That's what they're trying to say. So at severe levels of hyponatremia, this person can have vomiting, somnolence, seizure, coma, cardiac arrest. What is somnolence? Something to do with sleeping. Somnolence. Drowsiness. So this photo indicates perfectly hyponatremia. Okay. So we have seen all this. Now let's go to the treatment. What do you say, people? Hyponatremia. How will you treat? Right? In investigations, guys, you need not only check sodium levels and this serum electrolyte like I told you. You can also check the levels of this ADH and all that. Okay. Just to go one step next to find out exactly what the cause of the hyponatremia is, you can check this ADH levels, etc. Okay. So that also you add. We'll add here, wait. Investigations. You'll do serum electrolytes, that is. We'll check sodium, potassium, chlorine, and there's one more CO2 or something that we don't do in our hospital. Then focus people, what else you can check? You can check for ADH, etc. Okay. Now let's go to the next slide here. Hyponatremia, management. Okay. See people, sodium, what it does in your body, you understood, right? Water retention, water balance, all that it will help, okay? You have some sodium channels and all in your, you would have seen in your cells, right? So many sodium channels will be there. So all that, have you seen sodium channels, water, ATP, sodium, those channels you know, no? So sodium is very important, okay? So now let us go to the treatment, okay, of hyponatremia. Very simple, give them sodium or just give them salt, like we put them photo here of salt. Correct, no? Just give them salt. And does it work like that? Okay, so basically you give them normal saline, okay? We'll show you that photo, wait. That time we showed you this one, see? Normal saline drip, because this person, it could be dehydrated. If the blood pressure is normal or low only, they'll give this saline because it is going to increase the volume, right? So, this is, it will prevent the water loss from cells. So, it will prevent dehydration. Okay. It will help the retention of water in body tissues. So, hyponatremia, if it is not something that is so causing any edema in the brain, etc., you can just treat it like this. Okay. There are basically two things they want to know. Has it developed suddenly or has it developed slowly? Okay, so if it has developed slowly, you treat slowly. Treat slowly. Okay, you can, you should not do rapid correction. Don't do rapid correction. Okay, because the brain will take time to adapt. Okay, because the brain is fine, because it was slowly, it has reduced, right? Slow hyponatremia, if it was there, then you treat also slow. Don't do rapid correction, they are saying. But if it is a rapid hyponatremia, what would have happened? There could be cerebral edema. So if it is within 48 hours that this has happened, then there could be cerebral edema. You will give hypertonic sodium chloride. Okay. An initial bolus of 150 ml over 20 minutes and then you will repeat as needed. Okay. Hypertonic. Remember, hypertonic, 3%. So guys, treat the cause, basically whatever the cause is, vomiting, diarrhea, all that you will treat, right? Burns, how will you treat? All that you will treat, okay? In burns, the main treatment itself is giving saline, right? Do you know that? The main treatment for burns itself is giving fluids, right? Saline. Okay, so treat the cause like we told you, right? Then if the person is having enough volume of water, then you have to do fluid restriction, right? Then if he's having this SIADH, that is he's having severe ADH is more actually, okay? Then you'll give oral urea therapy, they are saying. So body will try to remove the urea from the body. That time there will be no water intoxication, I'm thinking, right? Focus people. Potassium sparing diuretics can help if there is significant secondary hyperaldosteronism. Okay. So basically you are going to try to remove the water, right, from the body. Diuretic. Then what is this? There is some there is some drug called as tolvaptan, okay, tolvaptan, which will, it is a oral vasopressin receptor antagonist, okay. So if this vasopressin is more, then you can give this tolvaptan, right. So what will it do? It can rapidly correct the hyponatremia, but so there is a risk. It will correct rapidly, so you should be very careful. They are saying ORS normal saline, we told you. In ORS normal that you will get 75 millimole per liter sodium, correct? Yeah. Then normal saline, do you know the percentage? 0.9%. See, it is only 0.9%, okay. So we'll write that here. This is only 0.9% it is. So when they are telling, if you want to give if there is rapid hyponatremia and you want to correct it, right, that time you'll give a bolus, right? They're saying that time you should give the 3% sodium chloride. Focus here, people. The normal that one that we always use is a 0.9%. But in the case where you want to give the hypertonic, that is 3%. You got it right? Yeah. Let's take a quick recap. In this video, we want to look at hyponatremia, right? That is low sodium. So basically normal, it should be 136 to 145 millimoles per liter. So basically if it is less than 135, see, it will be hyponatremia. So the causes can be excessive loss like in vomiting, diarrhea, renal losses that through urine, or it could be burns, so skin loss, right? So that is the cause of hyponatremia in terms of losses being more. What about excessive intake of excessive water, they're saying, like polydipsia, right? Polydipsia, you're drinking too much water. Then you're giving somebody water infusion like in prostatectomy, or you're giving dextrose that time. So electrolyte free water infusion is happening, or there is SIADH where there is ADH is more, vasopressin is more, so it is retaining more water intoxication. Hypothyroidism, edema will be there, so water retention. Then there is hypervolemia, so there is more like a dilutional sodium level, right? So like in heart failure, liver failure, or kidney failure, the person is not having so much of water retention, so that will cause a dilutional kind of a hyponatremia. Okay, so then what are the clinical features? These people will have some if it is up to like, if it is a mild, then they will have no symptoms. But if it is moderate, they can have nausea, delirium, headache. Okay, delirium. So delirium means what? It's a false belief, right? Kind of a thing, delirium. Severe means they'll go into vomiting, somnolence, they'll sleep, right? Seizure, they can have coma, cardiac arrest. Clinical features. And when you can understand that acute hyponatremia will lead to cerebral edema. So basically if acute hyponatremia, it will lead to cerebral edema. So if it is a slow hyponatremia, not much of a problem, body will adapt. But if it is acute hyponatremia, cerebral edema. So if you want a person to have acute hyponatremia, and why will he have acute hyponatremia? I'm thinking somebody gave him these diuretics probably, right? And he lost a lot of sodium. Acute. Why will it be so severe, the loss, I'm thinking, right? It could be a way of killing somebody. So you should always be careful about these poisons when you're in forensic medicine. So investigations, you can check for the serum electrolytes, you can check for ADH levels, okay? Then management. So you will treat the cause. So basically, if water levels are normal in this person, then you can ask him to restrict fluid. If the water is excess or thing, you can ask him to restrict fluid. Then you can ask if ADH is more, then you can give an oral urea therapy. Basically, you're trying to get the water out. Diuretic type, potassium sparing diuretic again they're talking about. Then there is a vasopressin receptor antagonist, tolvaptan. This can also release the water, right? But this can lead to, this can lead to rapid correction of the hyponatremia, which is also going to be dangerous. Rapid correction also is bad. ORS, normal saline, all these things have sodium. ORS has how much sodium? 75, right? 75 sodium, right? 75 sodium it will have. If somebody is having vomiting, diarrhea, they'll suggest this oral salts. So you can see here sodium 75 milliosmolar per liter. Okay. Then let's go back here. Then slow hyponatremia and normal saline is 0.9%. Okay, remember. And you should always give it after checking the blood pressure. If blood pressure is less only or normal, they are giving normal saline. Okay, saline drip they'll give, and you should control the rate at which you give also. Right? What will happen if you give very fast? Sodium levels will increase. That is very dangerous. Yes. Otherwise, the blood volume will increase. The blood pressure will increase. Okay. So you should be very careful. Then, where were we? Yeah, here. Normal saline is 0.9%. Then, if there has been slow hyponatremia in the person, you will correct slowly only. But if there has been rapid hyponatremia in this person, that means he has lost sodium very rapidly in the last 48 hours, something like that they are saying, then there will be cerebral edema, like we told you. Right? So what will happen if there is cerebral edema? Then you should correct it also rapidly, they are saying. So you will give hypertonic sodium chloride, that is 3% sodium chloride. Okay. So initial bolus of 150 ml over 20 minutes they will give, and then they will repeat as required. Okay. So this is all about hyponatremia. People, hope you have understood hyponatremia. Okay. So just as a closing note, I will tell you, nowhere they talked about the ECG changes, etc. But that all that ECG changes we saw in potassium changes. Potassium changes, we saw ECG fluctuations. Sodium, nowhere they have mentioned ECG changes. Okay. So remember, hyponatremia we have covered. Bye bye. This saline is actually a crystalloid. Okay. You can see here saline, ringer lactate and dextrose, all these are crystalloids. Okay. Even ringer lactate will have sodium, right?